Hello, everyone. Are we ready to get started? Thanks for joining us today. My name is Brian Chapman, and I'll be moderating the panel today on health equity. I'm just going to ask my colleagues here to introduce themselves quickly and tell you a little bit about the business where they work to put some context in place.
Hey, good morning. Thanks for being here. My name is Ivan Tornos. I'm the president and CEO of Zimmer Biomet. We are in musculoskeletal care. We're a company out of Warsaw, Indiana, with close to 100 years of history, dealing with all kinds of pathologies, whether it's hip replacement, knee replacement, shoulder extremities, but we also get into other areas like cranial, maxillofacial, thoracic. So happy to be here.
Hi, I'm Larry Wood, Edwards Life Sciences. I'm corporate vice president and group president of our transcatheter heart valve business and our surgical structural heart business. So I pretty much do heart valves and not a lot of anything else. And very focused on how we can make improvements in healthcare inequities because in the cardiovascular space, I think it's probably one of the worst examples we have.
I'm Nina Goodhart from Medtronic. I'm the Senior Vice President and President of our Structural Heart and Aorta business. Medtronic covers almost every disease state that we operate in MedTech. We're a $30 billion MedTech company. My focus is structural heart disease and aortic disease.
So we have two people who will duke it out in the marketplace, but also both very focused to making an impact. Both very focused on making an impact in health equity. One of the things I think we're going to define it a little bit differently as we go here, but I would love to hear, maybe Yvonne, if you can start. When you peel it back, what do you think some of the root causes are?
Sure. Thanks everybody for being here. Before we get into the topic, I just want to say thanks to CS for putting the topic on the stage and for the many companies that are actually actively working on health equity. This is a topic that's been around for a while. I think for many years we talked thematically about the issue, and over the last 2-3 years I've seen people really truly engage in trying to solve the problem in a meaningful way. So it's great to see that we're starting to see a bit of a revolution in terms of how we address the issue. So health equity, what is it and what is the root cause? The root cause, I talk about 3 C's. I talk about complacency, confusion, and commitment. Complacency, let's just address the fact. Most of us are not in that bucket. Most of us are okay with the way that healthcare is delivered. The majority doesn't see the issue, and when the majority does see the issue, we tend to not do much about it. We're complacent. Number 2 is commitment. This is, as Edmond, my head of this initiative, Health Equity for Zimmer Biomet, talks about, this literally takes a village. When you think about the problem, this is not just donating to a certain foundation. This is not talking to a certain group of partners. This is not just AdvaMed dealing with it. This is not interacting with physicians. It takes a village. It's truly a multi-stakeholder approach. And most of us don't want to have that commitment to get that deep into the issue. And then the third C is confusion. We are confused in terms of what is that we need to do. Some of us don't even know how to explain what it is and how it's different from DEI, whether it's philanthropy, whether it's part of a business. So what is the issue? So I would say the complacency, the confusion, the commitment are the 3 major reasons of why we have these health disparities. Now, in a data-centric way, 80% of the issue is what is called social determinants of health. So the reason why we have inequalities, the reason we have such a discrepancy between certain groups and other groups is social determinants of health. That accounts for 80% of the problem. Your zip code, where you were born, where you live. I read a quote which is very thought-provoking. That has a greater impact on your health outcome than genetic DNA. I'll say that again so the accent doesn't get in the middle. Where you were born, your zip code, will have a greater impact on your health outcomes than genetic DNA. That's scary. So where you were born, where you live, how close you are to some sort of healthcare facility, what you eat, how educated you are around not just academics, but just in general. So those are the main reasons why we have this situation.
Yeah. We got really deep on this when we launched transcatheter heart valves, which is a way where you can place people's heart valves without open heart surgery. And what we found, there's a national registry, so we were getting probably the best data we ever got in the commercial setting. And while blacks make up 13% of the general population, they're only making up less than 4% of the registry. And even over time, after a decade in the market, it hasn't fundamentally changed. And when we dig down into the issues, one couple things. One, people will say it's complicated and multifactorial, but that can't be an excuse to do nothing. And unfortunately, that's what happens a lot. People want a silver bullet, one solution, and then move on. And there's no silver bullet to healthcare inequities. But I think there are some common themes. Social economic issues are certainly one that plays a role. But trust is another huge issue in communities of color that plays a massive role. And I will say, and I speak about this a lot, and I think there can't be an elephant in the room that we're unwilling to talk about, because we're never going to make change if we do that. We can't, on one hand, continue to spew distrust of the healthcare system and then decry healthcare inequities. We have to earn the trust in communities of color so that they trust the system, so that they'll seek care. But no one is going to get better care if they don't enter in the healthcare system. And so we're going to have to do things to fix that basic distrust we have of the system if we're going to move things forward.
I think that's right, and instead of repeating, I think maybe I'll just build on what my colleagues have said here. Clearly what we need as well is some intentionality from all of the stakeholders involved, right? And so we have to take this enormous issue that we have. We've got to focus our efforts on government initiatives. We've got to focus our efforts with medical societies. We've got to get industry involved. And what we have seen to date are pocketed initiatives. So we have some things coming from the government, we have some things coming from industry, but none of those are at scale. And so we can't make a meaningful difference. And so if we can start to put some of that together, I think we could actually make some progress.
So I really like this. We've got the 3 C's from Yvonne. We have trust, a really important part, and then about scale from Nina. I wonder if, I was looking behind me and it says from words to practice. So I would actually love to hear from each of you some of the things that you're doing so far, some of the progress that you have made.
Yeah, I'm going to over-index on one of the 3 C's that I mentioned, which is commitment. Be fully committed to transform how health is delivered in the U.S. and around the world. What are some of the things we've done here? We started a group of people with a leader, a high-potential leader, that is doing this full-time with the right level of support. We treating this, I hate to say it, but it's a reality, like a business. What does the dashboard look like? How many patients do we need to have access to? How many surgeons do we enable to be practitioners in the right groups? How do we rethink or practice around new product development? We didn't have these discussions early on in the new product development cycle, so we're rethinking how we do that. How do we think about M&A? Are there different targets that we should be purchasing that address this issue head on, and we can save some time, so we won't wait 5 years to do this? How do we make sure that we address some of the issues around concordance in care? The reality is that patients want to be around patients that sound like they look and sound. And that's something that we can do a better job in MedTech. We partner with a lot of different societies going 10, 20 years ago that are bringing a higher representation of females, minorities, blacks into the US. In orthopedics or space, we have about 33,000 surgeons in the US. 2% of them are black African Americans, 6% are females. We can help that issue. We can partner with the right partners to make sure that we have a higher representation of females. So that's a little bit of the things that we're doing, but it starts with commitment.
Sure. So we're looking at this holistically across Medtronic as we think about how do we do our clinical trials differently? How do we provide infrastructure in underserved communities and in hospitals that we normally would not have gone to from a clinical trial perspective? How do we ensure that we are working across boundaries to be able to make that happen? But we're also understanding we can't do that by ourselves. So we have partnered with the American College of Cardiologists to look at how we train physicians in underserved communities so that they can both treat pragmatically, but that they can also enroll patients in clinical studies and get to that trust factor that Larry is talking about. We're also doing clinical trials. So we have a clinical trial right now called ALERT. It's in 10 sites in the southeast of the United States, specifically in underserved communities. Again, building that trust and building that data. We have a trial that we're running called the SMART trial. It's 90% women enrolled in that trial. And so we're looking to be, like I said, as intentional as we can, building up the data, driving up the scale.
Yeah, I'd say we've had a lot more success in gender equality in trials than we have in people of color. And, in our original partner trial, we had about 50% women. We're running a trial in Europe that's exclusively women to try to show how the technology benefits women, maybe even disproportionately. And so I think both of us have done a lot of work in that area. Communities of color have definitely been a harder one to crack. And the part of the problem is communities of color, when you think about it in the commercial setting, there's all this under treatment. That's exacerbated in the clinical setting because in the clinical setting, you're only in maybe 20 or 50 sites, and those tend to be in really exclusive high volume areas which don't tend to serve minority communities as well. But what that means is you don't have a lot of data on communities of color on the basic disease. And so one of the things that we did was we did a partnership with the NFL Players Association where we studied former NFL players because it was a way to bring everybody in, but we knew we would disproportionately pick up people of color because that's the makeup of the NFL. And so we look forward to publishing that data later this year, and we can try to continue those partnerships and do that. But I would say as much as people want to focus on the clinical trials, I feel like that could be a red herring, and here's why. If I have to run a 700-patient trial and you say I have to have 13% people of color, I know I'm going to pick up 7% just in the natural course of things, so I need 45 more people of color. I can just brute force 45 people into a trial and then raise my hand and say, look what I accomplished, I got 13% representation in the trial. But if that only leads to 4% of the general population having commercial access to the therapy, then we have fundamentally failed. And so I'm much more focused where we have 850 sites that have access to TAVR. Why aren't we doing a better job in communities of color? And maybe we need to add another 250 sites that are specifically focused in communities of color in rural areas because what you said about zip code is right. And Clyde Yancey does a great talk on this where he says it's place, not race. And the place you are, it almost doesn't matter what color you are. The social and economic impact is so powerful. And the health inequities, and they're not just related to MedTech, the nutritional inequities, all of those inequities play a huge role.
I think that's right, Brian. And Larry and I have had the opportunity to talk about this many times, and I think you would agree, it has to be both, right? We need the data, we need to build that up, and then we also need to be pragmatic and we need to expand our patient access. One or the other isn't going to do it. We've got to do these in tandem.
I wonder if you could talk a little bit more about bringing the therapy to the patient. So certainly place matters. And I know some of you mentioned that there's also this notion of physical access. Any comments here?
Yeah. Well, I'll offer two quickly here so that everybody can elaborate. One is we gotta leverage digital pathways and applications like the one we have here at Zimmer Biomet. We call it MyMobility by Apple, where you can bring care to patients in unique zip codes, pre-surgery, and after surgery. So there is all kinds of opportunities when you think about the digital care pathways. So that's one of them. The other one, which is an ambition that we have here at Zimmer Biomet, is about bringing care to ASCs, even built ASCs in some of these places where you don't have the same access to care. And this is something that we're going to be doing, partnering with different groups, and something that is very bold and very exciting. Because if you do manage to get an ASC in these zip codes, with people that look like the people that will go to those zip codes, having the same type of technology that you will have in other zip codes, I think that's transformational. So those two things will offer, the digital care pathways and then the opportunity within the ASC.
Policy plays a huge role here. And I will tell you the national coverage decision that came out that we were all a part of, so this is not me taking a shot at CMS or any of the government agencies. The entire focus was how do we protect patient outcomes? But part of the problem that's broken in our healthcare system is once a patient enters the cath lab, we know every single thing that happens. We know how much contrast you used, the minute they got in, the minute they got out. We know everything about them. But if you're untreated with the disease, we know nothing. We don't track it. If you die with aortic stenosis and you're untreated, that's somehow God's will. But if you die getting a device, then that's somehow a Greek tragedy. And what ends up happening is, if I look at the first three centers that we opened in the Southern California area where we are here, Beverly Hills, Newport Beach, and Westwood, not exactly what you would call heavy minority communities. And because government policy was all dictated about making sure we had centers of excellence, so we delivered spectacular outcomes. But the problem is patients have a 50% mortality rate within 1 to 2 years if they have severe aortic stenosis and it goes untreated. And somehow the risk of, we have a less than 1% mortality rate with this procedure now. Let's say you went into communities of color and you went to lower volume hospitals and they had less infrastructure. Let's say that doubled to 2%. There'd be a whole bunch of people that would say that that's a tragedy, but somehow people dying at 20% a year nobody thinks anything about. And we have to start measuring what happens to untreated people as hard as we start measuring what happens to people who are treated. Because if we start looking at it through that lens, we'll make better trade-offs on the risk benefits of opening up access to patients.
I think that's right. And I think what we've learned over time is that healthcare has to be local, right? And so while you may have a center of excellence 10 miles from you, if that is not in your community, with your physicians, with people who look like you, you're not going to go. And so while on a map it looks like everybody has access to healthcare, we see that in New York City, which is where I'm from, right? If you live over a bridge, you may not be going into New York City for your care. The cost of doing that, you have to park, you have to get lunch, it's an all-day affair, it's cost you $300, you need 5 follow-up visits. You're not making that trip. Although on a map, we would say, you've got 5 centers of excellence right within a 10, 15-mile sphere. So I think we have to rethink how we look at care, and we have to understand that people want to go close to home with physicians they trust and in communities that they care about.
So just to Nina's point, we did this study in Los Angeles, and if you look at where TAVR centers are, they literally surround communities of color. And we took a person from the CMS database who has severe aortic stenosis, 73-year-old female. She's had aortic stenosis, hasn't been treated in 2 years, which we know what her risk factors are. And Cedars-Sinai is just right up the road. It's like 10 miles away. All that would take her is 3 buses, 46 stops, and an hour and 46 minutes one way, and 10 minutes of walking for our 73-year-old severe aortic stenosis patient who probably is not going to make the trip on her own, which means her daughter or her son is going to have to take the day off work to go with her. And on average, and Cedars does it better than probably just about anybody, but on average, it takes 10 to 13 visits before a patient gets their TAVR for all their screening and all their workups and seeing 2 surgeons and all the things that go into this. So when you talk about localized, it's not just how many miles away. A bridge will make all the difference, even if it's 5 miles away.
Just want to throw quickly, just 1 second here, on the comment that Larry offered around the data of untreated patients, and we need to understand what is the cost. We actually track those data points. So there is $93 billion every year in the U.S. That's the cost of not treating properly some of these groups. So that's more than the revenue of the 3 companies here represented. So one data point. The other data point is that just in orthopedics around $6 to $7 billion every single year. And that doesn't account for every single cost associated with non-treating. That's just the direct impact. When you think about productivity, when you think about labor, this is a major, major problem across the board.
You know, you guys have mentioned several times some pretty shocking stats. And I think what would be interesting is how do we think about metrics, and how do we elevate those metrics so that it's less about, so they become a part of what we actually optimize within the business?
Well, I think we talk about them all the time, but I don't know that there's great awareness of these metrics, right? And so as Larry mentioned, we know so much about half of the diagnostic journey, but we know almost nothing about the beginning. We talk about that. We have conferences like this where we talk about that, but I don't think that's common knowledge. So I think we have to continue to build that awareness so that those stats make a difference.
I think there's education, but there's also accountability. When we need to make the starting line. In our case with valve disease, it'd be different for every industry. But for valve disease, the starting line where you get measured should be when you've had a diagnostic echo that says you have severe aortic stenosis. And if the starting line is there, then there would be a time to treat metric, and there would be a time to referral metric, and there would be all these metrics that would not allow people to just get lost in the system. And that's what happens right now. On average, from diagnosis to treatment, it's more than 6 months for the average AS patient with a disease that has a 20% mortality rate a year, 50% within 2 years. So that's just kind of really archaic. And if we start building those metrics in, and hospitals start to have to track, like we did with door to balloon and like we did to other things, where time matters, and time is an easy metric. It's easy to measure when somebody got an echo and it said they have severe aortic stenosis to when they get treated. And if hospitals started to be accountable to that, it would be a complete game changer.
You gotta start somewhere, and I agree with both of my colleagues. There is not a perfect set of metrics, but we came out with a set of internal metrics that we track, and I alluded to some of those at the very beginning. Access, how many patients in certain areas are we getting into the system, into the funnel? Percentage of surgeons that we're educating every year that are going to these underrepresented communities. Percentage of product within new product development that we allocate from an innovation standpoint to treat some of these comorbidities, some of these diseases that are more prevalent in certain areas. percentage of investment that we allocate into a certain zip codes. So again, we're not going to solve this in the most perfect way, but you got to start with a set of metrics, and we got those.
So as we think about, all three of you are with large public companies, and there is an inherent tension between the notion of business and philanthropy. I wonder if you have any thoughts on how do we tackle the issue of healthcare inequity in the context of is this about philanthropy or is this about business?
I think it's one of the confusions that all of us have at the very beginning. So again, when this was presented to me a couple of years ago, I didn't know, all right, we're going to build this group around health equity. So do the reporting to HR as part of DEI, do the reporting to the foundation, do the reporting to the business. And what we landed is that this is really something where you have the intersection of everything. We got to treat it as a business. This is not giving money for free. That's the old, let's give somebody a fish today. This is like really build a platform we can build upon. So today, this is a business. We treat it as a business with a dashboard, with high potential leaders. So this is not giving money for free, a one-time type of event. This is building something with our customers. Customers being patients, physicians, providers, and payers. So at Zimmer Biomet is very clear. This is another business unit that is all over the other business units, but it's part of the business.
I think as we've looked at this, we've tried it both ways, right? And I think my guess is that we've all done this, right? We all have philanthropy organizations. We have gone into underserved communities. We have brought in free technology. We have done those procedures. We have helped a select number of patients, and that's wonderful. The problem is that when we leave, there's no infrastructure that was built. There was no training that was built. And so we have been in situations where we have donated free devices. We go in, we do a couple of cases, we leave. Those devices sit on the shelf until they expire. So patients are not being treated. So we have to build infrastructure, we have to train, we have to educate, we have to measure, but it can't be just philanthropy. It absolutely has to be a business strategy that's part of everything that you do. This is a patient access issue, right? Our goal for these three companies, for all the companies here, is to serve patients, to serve all patients. Nobody has a mission that says we're only going to serve this select patient group. And so this has got to be built into our business strategy so that we are working to bring these incredible technologies to all patients in all communities all over the world.
Yeah, I completely agree with Nina. And if addressing healthcare inequities was an R&D project, the president of R&D would have been fired years ago. Because if you look at what we've invested in this and little progress we've made, it's really disappointing. When we think about the philanthropic side, my whole focus on it is it sustainable? And actually with my surgical business, I can go donate products. I can send surgeons into a region. They can teach how to do the procedure because they have cardiopulmonary bypass. And that's really the skill of the operator that's doing it. And we can build sustainability that after we leave, the devices get used. And even if they don't buy our devices because they buy some less expensive device, that's okay because we've developed sustainability and it'll be okay. But I hate doing things for window dressing. And we both get approached about doing medical missions, and they donate 10 products and we go to some far off land and we do 8 cases and everybody takes pictures and videos and put it on their website and says what wonderful people they are. And we've helped 8 people and we probably spent $1 million to do it. I would have rather taken the $1 million and bought penicillin for that area where everybody lives and eradicated rheumatic fever, and it would have helped far more people in a far more valuable way, but it's not going to get you in the newspaper. And I want to build things that are going to be sustainable. And there's places for philanthropy where we can do medical missions and we can donate devices and it's really powerful and we can build sustainability. And there's places that you take your high-tech technology and it doesn't really move the needle and it doesn't do anything. And we have to be very thoughtful about how we spend our money in this area because at some point it's a fixed amount of money and you have to make sure you're getting the most bang for your buck. But I think it is about sustainability, not about getting 2 devices used in Peru and thinking you're a genius.
Yeah, I really like that. I think this idea, the idea of having a report into the business, using metrics as a business, really applying what we do best to solving what seems to be otherwise a very intractable problem. I wonder if you could talk a little bit about the diagnostic pathway. So I think it's very easy for us to imagine surgeons and expanding surgeons and helping surgeons look more like the people we're trying to help. But what about the sort of upfront, especially for such a path in cardiology where they where many people may not even be under the right care to begin with to be diagnosed. Any thoughts there?
Well, I think one of the things we've been looking at is how do we identify these patients up front, right? We're using AI tools in a lot of our hospitals to identify patients with aortic stenosis to get them at the very beginning of that pathway so that we can pull them through. We're also doing just simple pragmatic things, right? Our sales organizations have to mirror the patient populations and the physician populations that we're in. When a patient comes into a hospital, they have to see people who look like them so that they start to build trust and continuity. And then we've got to get them earlier. You know, Larry mentioned the fact that we have no information prior to that beginning of the cycle. We've got to back that up, right? If we've been able to do time to balloon, if we've done time to brain and stroke, we absolutely have to be able to do that here.
Yeah, I find it ironic that you turn 50 years old and you get the gift of a colonoscopy, which is a miserable test with miserable prep and miserable everything, and there's no national standard for what age you should get an echo that, unless you're allergic to the gel, has no adverse effect on you and tells you so much about your heart health. We can pick up arrhythmias, we can pick up, we pick up hypertension, we pick up all of these things, any diseases of the aorta, all of this. In the study that we did with NFL players, we did 9 screening events across the country. At every single event, somebody left and went directly to the hospital because we found something on echo, just an echo and an EKG. And we didn't even do a blood draw because we thought that turned too many people off. But just with that information, we were able to detect multiple problems. And having a national standard where everybody above the age of 65 or above the age of 70 would get a diagnostic echo, we could really transform how patients with cardiovascular disease get treated.
You know, I was thinking when we were talking about metrics earlier exactly about colonoscopy and wondering, why don't we have national standards? So it kind of brings us to maybe the last topic we can touch on is this is obviously not an issue that you're going to tackle completely on your own. The two of you, of course, can sort of swim in the same lane together, but there has to be cooperation and collaboration with other partners. I wonder if you could give us some thoughts on what else do we have to see from the industry, from the environment around us to help out?
I would say, first of all, the list of partners. We got 2 minutes left. It'll take me 2 days to go through the list. AdvaMed, FDA, medical societies, us as an industry. We're not doing anything as an industry together. Edwards working with Medtronic, Zimmer Biomet, Johnson & Johnson. It takes the patient to be involved. It takes the providers, hospitals. It takes healthcare systems. It takes payers, Cigna, United, Blue Cross Blue Shield, Aetna, CMS. It takes government. It takes advocacy groups. It takes a village, again, as Edmond says, so it's a large group of people. Start somewhere, pick 1 or 2 key stakeholders that want to move the needle forward and be very concrete.
We have to be ready to break stuff. And my biggest frustration is, and Nina and I sit on all these panels together and we try to be great partners on this stuff because it's something that unites us, it doesn't divide us. And my takeaway is on all these panels, we're going to agree to be outraged. And we'll get together and we'll talk about how outraged we are. And then we're going to commit to bold and decisive action to drive real change, as long as it doesn't require government policy, it doesn't upset referral patterns, it doesn't cost any money, it doesn't make anybody angry, and everybody's okay. And that's not going to get anything done. That just leads to these very small incremental changes. We have to be ready to break things, which means breaking things like government policy, breaking things like making the outcome in the cath lab the only metric that we care about. We have to start looking at undertreatment and start holding people accountable and hold us accountable. If we open up these small hospitals, we're still accountable for the outcomes, and it's our job to train. And maybe in a big hospital we proctor 3 cases. Maybe in a small hospital we have to proctor 20. Okay, so be it. Let's go do what we have to do to make this stuff happen. But it's going to require policy change. It's going to upset some of our customers because they don't like new competition around them. It's going to break all those things. And so what? If we're going to make change, we got to go do it.
And this is why you got to have this as part of the business, repeating myself, because then you'll have business people talking to business people. And then that is when action happens. When you have business people bringing data to business people, talking about why it's a good business for you, dear payer, dear provider, to address these issues. Short-term pain, long-term gain type of approach.
And maybe I'll end on a positive here because this is such a huge and challenging issue. But at the end of the day, there are very few things where competitors can sit together and work towards something that's critically important that they can align around. Patient access, bringing technology to patients in areas where they're not getting it now, being really intentional about that, partnering with the government, partnering with all of our stakeholders, and really working towards meaningful change, not being concerned with challenging the status quo, but actually rallying around challenging the status quo to be able to make a meaningful difference, this is one of the areas I think we can do that.
Wonderful. On behalf of everyone in the audience and myself, Nina, Larry, Yvonne, thanks so much for your time and your insights.
Thank you, Brian.